The academic unit of primary medical care at the University of Sheffield supported the development of a Sheffield Deep End cluster of the National Institute for Health Research Clinical Research Network and Deep End Patient and Public Involvement Group, starting in 2016. This collaboration is now known as the Deep End Research Alliance, Yorkshire and Humber. The collaboration aims to support researchers to design research which takes into account the needs of populations in deep end practices and support those practices to take on board research which is relevant to their patient populations. The overall aim of this is to understand and challenge health inequalities and an equal distribution of resources.
I'll start at the beginning because it's really important that, what drives us all is this thing called the inverse care law, and that's that even in nationally funded health systems, often those who have the greatest need of public services often have the poorest access to care. There's discrimination at every level of the system in how things are funded and who shouts loudest. So the Deep End movement started in Glasgow about over 10 years ago, and over that time they have changed general practice in their areas for the better. They can't change a lot of the things that are external, but they've changed the ways that people receive their services that better suit their needs, and they've shouted loudly for their communities. So Sheffield set up a mini Deep End, and we brought together a group of general practices which were committed to making change for people living in poverty and for people that are very easily excluded, and there's lots of reasons for that, for people who are underserved and people who are seldom heard. To do that, it needs to include the people with the highest health needs, because that's where most of the health problems are concentrated. So if we don't bring research out to the people who really need it, then actually those people are denied the opportunity to have better health. Around 2015, a lot of this has involved getting some funding in to support the development of bringing practices together and to bring, what we feel has been absolutely crucial right from the beginning is public and patient contributions. We would like your voices to be heard and to shape the sort of research we do and how we do it. What we did what we call qualitative research, which is when we go to people and ask about their stories and experiences of healthcare. It's a very powerful way of bringing the voice of patients to the world, if you like. This Walton moved on, Tom's taken over. We had the pandemic. What a terrible time. I don't even know how we've all managed to carry on at university and Deep End PPI, but thank you for still coming along. So here we are, 18 months on, and I cannot believe the amount of progress. Kate has joined. Obviously that's been, a big change. And we've got other researchers. We've still got the younger doctors, younger nurses, pharmacists, people coming through who are doing sort of projects which have been designed locally, and we come out and recruit people from communities. We thought that if we asked researchers to come right at the beginning and actually talk about their ideas, then they were much more likely to be relevant and useful to patients. So right from the first PPI meeting, there was a bell in the middle of it. So when the researchers came, so we had joint doctors, academics and patient meeting. So when we had the meeting, we had a bell in the middle of it, and if anybody said something that couldn't be understood by everyone, somebody would just stand up and bang it. And then the researcher would have to sort of suddenly find just normal, plain English way of explaining what was happening.
The recent pandemic proved what I am saying. Look at the disproportionate death of ethnic minorities. Why? It goes back to the question of inequalities. If you go back into the history of health research, look at how the minorities have been researched upon. And that's where the ethics comes in research, where before you get into modern day research, you have to prove that you will not disadvantage a particular race, a particular sector of people, a particular, and so on.
Against inequalities, I live in Birmingham, which is a poor area. We've got the highest levels of pollution, highest in Europe, not just Sheffield. We've got the highest incidence of children with asthma and adults with lung disease.
So it's really just about getting everyone's voices out there, getting them thinking, and hopefully by the end we'll come up with some things that we feel are our, kind of the group's key priorities and actions.
Maybe we need to have approaches tailored to particular communities where there are particular issues. So we might need to think kind of flexibly.
So
talking about health and about improving health. So again, diversity can be people with multiple health problems, because actually there's something about their experience of care that really brings the research alive. So people with disabilities or different kinds of physical health problems, people who've got lived experience of just navigating healthcare on a regular basis, I think is good.
Without those pauses and reflections to think about the next steps, you can sometimes limit yourself quite a lot, and actually by dreaming and thinking bigger, it allows you to kind of put things into place to enable you to get to those places. So accomplish great things, we must not only act but also dream, not only plan but also believe.